What we know for many decades is that small cell lung cancer treatment unfortunately remained the same. There was a desert of advancements. There were many negative trials, and really it seemed like we could not break through this cancer. And so the treatment with platinum etoposide, whether that's cisplatin or carboplatin, in combination with a topoisomerase inhibitor, etoposide, has been the mainstay for almost 40 years. It wasn't until the late 20 teens where we saw the implementation of immunotherapy with atezolizumab and durvalumab that really seemed to help move this field forward and break open the hope that we see today. So this is a slide showing the advancements and approvals that have been for small cell lung cancer in just the past 4 years. I do believe this is the beginning of many exciting advancements that we'll see for small cell lung cancer for extensive stage and limited stage. So let's go through these together. This is a really nice review that was published earlier this year that shows the treatment landscape for patients who may have limited stage or extensive stage. What we know is that the majority of patients who are diagnosed will have extensive stage small cell lung cancer. But as we have seen, about a third of patients have limited stage, and I believe that that number is going to keep improving and going up as we implement and effectively screen patients for lung cancer by CT scans yearly. So what is limited stage small cell lung cancer? So that can be anywhere from stage 1 to stage 3, where extensive stage is considered stage 4. Stage 1 and stage 2 limited stage small cell, if there's no involvement of any lymph nodes, can be potentially resected or removed by surgery. This has historically been a number that's less than 5%. But again, I believe that this will increase over time as we implement lung cancer screening that currently is about 5 to 10% of patients being screened. We would love to see that number be 100%. If we catch it sooner, it's caught in an earlier stage. What we see is that here, if patients have stage 1 or stage 2 and they undergo surgery, that's typically followed by 4 cycles or 4 rounds of chemotherapy with platinum etoposide to help to reduce the risk of this cancer returning and help cure patients. What you can see is if you do have lymph nodes that are positive, whether that's in the side of the chest where the cancer is found or the center of the chest, meaning the mediastinum, then that would be stage 2 or stage 3. If that is confined to one area of the chest, meaning the right side or the left side, and there's no evidence of any cancer outside of the chest by a PET scan and an MRI of the brain, we see that then that is considered limited stage as well, stage 2 or stage 3. And that is recommended to be treated with chemotherapy and radiation therapy. Ideally, this is called concurrent or given at the same time. But for some reasons, patients may receive chemotherapy and radiation separate. Ideally, it's given together. The radiation is given either once or twice daily, Monday through Friday, set at a regimen by a radiation oncologist. And chemotherapy is given for 4 cycles with a combination of platinum and etoposide. The exciting thing that we saw this year was the approval just on December 4th of this year for limited stage small cell lung cancer, seeing the role of durvalumab or immunotherapy. So what is immunotherapy? This is a illustration that I helped publish a few years ago on the left that's showing the role of immunotherapy and radiation. That we can use these antibodies, which are infusions, that can help recognize proteins on the outside of the cancer cells to block those signals and to help promote the immune system to see and fight the cancer. How we really think about it is that we see, the immune system is being trained, as you can see here in the top right, to see good and bad. And these lymphocytes are now armed and ready to see the cancer, fight the cancer, scavenge the cancer, and hopefully provide long-term cure. So what we saw earlier this year at our ASCO annual meeting was the result of the phase 3 randomized double-blind control, randomized to placebo or treatment arm for the Adriatic study. And the results are shown here. What they saw was after patients completed chemo and radiation and were shown to have no evidence of the cancer growing or spreading, they were randomized to immunotherapy monthly for up to 2 years. What we saw from this study was an unprecedented improvement in survival by 22 months, automatically leading to the implementation and uptake of this amongst medical oncologists, and that this is now the new standard of care, as you can see here with the blue line, really improving survival, and this data is still maturing. So this is now considered the new standard of care for patients who are eligible, and talking to your doctor if this is right for you. Patients should receive durvalumab or immunotherapy after the treatment of chemo and radiation for limited stage small cell lung cancer, pending and permitting the cancer scans do not show any evidence of spread or grow after the completion of this regimen. This is a home run and the first huge update in 40 years for limited stage small cell lung cancer.